Hi, welcome to my presentation on Chapter 8, Articulations. And the articulations are just the joints. So this is the second chapter we're doing on the skeletal system this semester. The previous chapter we talked about was about bone tissue and the bones themselves, and the other major part of the skeletal system would be the joints or the articulations, which we're going to cover right now. So the function of the articulations is to connect the bones to each other in a way that allows them to move past each other so that your skeleton can move. And at the same time, they need to provide stability to those connections between the bones. And there's a general rule of thumb with all joints, which is that the more mobility is allowed by any given joint, the less stability it will provide. So the most movable joints, like the shoulder and knees, for instance, have the least stability in the body, and the joints that have the least amount of movement associated with them are the joints that are the most stable. And in fact, some joints don't allow any movement at all, and those are the absolutely most stable joints. An example would be like the joints between the bones that make up your skull. From the last chapter, you probably remember the epiphyseal plate, which is the place on a long bone where the diaphysis meets the epiphysis, and you can have growth occurring, longitudinal growth occurring in the long bone at that location. And it's made out of cartilage. So because the epiphyseal plate is made of cartilage and not actual bone tissue or osseous tissue, that means that we can actually think about it as being a joint, and it's actually classified as a type of joint. And if you're including the epiphyseal plate as a joint, then joints have an additional function beyond just connecting bones and allowing movement, which would be to allow bones to grow as well. So we're not going to go into specific joints very much in this chapter, but we will go over the naming conventions for joints in general. So if you come across the name of a specific joint, you will be able to know where that joint is at in the body and what it's connecting. So the standard convention for naming joints is basically just to state the name of the first bone that participates in the joint, followed by the name of the second bone that participates in the joint. The bone that comes first is usually going to be the one that is more proximal or more medial or more superior. But a lot of the time you can kind of switch it, so it could be either way. Just generally the one that is more proximal, medial, or superior would be named first. So you would just say the name of that first bone, except that the last syllable in the name is replaced with O, and then you say the name of the second bone, which would be the more distal or more lateral or more inferior bone in the joint. And where need be, you would replace the last syllable of that second bone's name with al or with r. So for instance, if you see the word metacarpal phalangeal joint, you know that that is a joint between a metacarpal bone and a phalangeal bone, or a phalanx. Since a metacarpal bone is a bone in the hand and a phalanx is a finger bone, that lets you know that that's a joint between the first bone, one of the first bones in a finger, and the rest of the hand, or the main body of the hand. In that case, the metacarpal bone is the one that is more proximal, therefore it's the one whose name comes first. And the last syllable, the all on the metacarpal, is replaced by O. For the phalanx bone or the finger bone, you replace the, I guess in this case that's a kind of a weird word, phalanx, so you would replace the last letter in that word with geal to make it sort of the finger bone, or phalangeal. For most bones that have kind of a less weird name to them, then you would just, replace the last syllable with al or with r. Another example would be an interphalangeal joint. That one is named with a slightly different convention because it's actually between two phalanges, or two finger bones. So that would be like the first or second knuckle of your finger. You could also call it a phalangophalangeal joint, but we would usually just call it an interphalangeal joint. And then we have some exceptions to those naming conventions. So some joints, are named in a different way. So it might be a little more difficult to know just from the name of the joint where it is in the body in those cases. One of the main examples of that type of joint would be the glenohumeral joint, which is actually just your shoulder joint. In that case, the glenoid cavity is a feature on the scapula that's actually a shallow depression on the scapula where the humerus kind of fits into it. So that's the part of the scapula where you actually have, the joint with the arm or with the humerus. So in that case, the scapula is the bone that is more proximal and the humerus is more distal. So the scapula goes first, but it's not named after the whole scapula. It's just named after that glenoid cavity where the humerus actually attaches, and that's why we call it the glenohumeral joint. Although again, sometimes you might hear it called the humeroglenoid joint if you're putting the name of the more distal bone first, which some people do sometimes. So now we'll go over the types of joints. There's two different ways that joints can be classified. They could be classified according to their function or according to their structure. The functional classifications are the synarthrosis, amphiarthrosis, and diarthrosis. Synarthrotic joint is one that does not allow any movement. An amphiarthrotic joint allows a small amount of movement, and a diarthrotic joint allows a lot of movement. So most of the joints that we're used to thinking of are going to be diarthrotic joints that allow a lot of movement of your body parts. There's also three types of joints classified by structure, which are the fibrous, cartilaginous, and synovial joints. The fibrous joints have the bones in the joint connected to each other using fibers of dense regular collagenous connective tissue, and there's no space between the two bones. Or I guess I should say there's no empty space between the two bones. You just have the bones, arranged pretty close together, and then whatever little gap is there is just filled in with the dense regular collagenous tissue. Then you have cartilaginous joints, where the joint is formed by cartilage, or the two bones are connected by cartilage. Again, there is no empty space in a cartilaginous joint. You just have bone 1, the cartilage, and then bone 2. The type of cartilage can vary by joint. And then finally you have synovial joints. In a synovial joint, there is actually an empty space between the two bones that are coming together in the joint. And that space is not technically like empty in the body. It's actually filled up with fluid that's called synovial fluid, which has a number of functions, but it's just kind of there to cushion the joint and provide some shock absorption for it. The synovial joint is going to have the two bones connected to each other by a kind of capsule formed of dense irregular connective tissue and also lined with loose connective tissue. Then that loose connective tissue is actually making the synovial fluid and excreting it into the space between the bones. Most of the joints that we think about having in our bodies are synovial joints. So all of your kind of common joints that you're used to thinking about, they're all synovial joints. Synovial joints are all diarthrotic joints that allow a good amount of movement at the joint. The fibrous joints and cartilaginous joints, some of them are synarthrotic, so they don't allow any movement, and some of them are amphiarthrotic and do allow a small amount of movement. So we will briefly go over the fibrous joints and the cartilaginous joints. Then we'll spend the rest of the presentation talking about the synovial joints in more detail. So we'll start with the fibrous joints. There's three subtypes of fibrous joints. What they all have in common is that in each case the bones are going to be held together by dense regular collagenous tissue. So by these little fibers of collagen. The first subtype of the fibrous joint is a suture joint, which is the type that you find in the skull that forms between the cranial bones and the facial bones. So in a suture joint, the edges of each bone have this complicated pattern to them, kind of a teeth-like pattern to them, and they fit together like almost perfectly. And then the tiny little gap between them is just filled in with collagen. Suture joints don't allow any movement, so they are synarthrotic joints. Then you have the gomphosis, which is a very specific type of joint that's actually only found between the teeth and either the mandible or maxilla of the skull. In the gomphosis, you have little cavities or little sockets in the mandible and the maxilla that are designed to fit each tooth. So the tooth fits in there like a peg into that little socket for it. And then you have these little ligaments made out of collagen that stretch between the bone and the tooth, or between the mandible and the maxilla or the tooth. Those little filaments of collagen actually count as a type of ligament. Technically, those are called the periodontal ligaments. So you might think that the gomphosis would be a synarthrotic joint because your teeth don't really move in their sockets, but they actually do move a tiny little bit. It's actually possible for them to be pushed a little bit deeper into the socket when you close your mouth with some force. So they're technically categorized as amphiarthrotic joints. Lastly, you have the syndesmosis, or the third type of fibrous joint. That's also a very kind of limited type of joint that's only found in a couple places in the body. In a syndesmosis, the two bones in the joint are kind of lined up with each other, like parallel to each other, and you have a structure of collagen fibers running between the two bones along their length. That structure is called the interosseous membrane, or sometimes the interosseous ligament. There's two examples of a syndesmosis in your body. You have one in the arm that's between the radius and the ulna, and you have another in the leg that's between the tibia and the fibula. Out of all of the fibrous joints, the syndesmosis is the one that has kind of the biggest gap between the two bones in the joint, but it is entirely filled up with collagen, the collagen fibers of the interosseous membrane. So it's not like an empty space or anything. And that type of joint does allow some movement, so it is an amphiarthrotic joint where the two bones are able to kind of rotate around each other a little bit. So actually, if you hold your arm down at your side, just in its kind of most natural position, your palm will be pointed in towards your body. Then if you were to rotate the palm outward to face forward, like if you're to get into the anatomical position, in order to do that movement, what's actually happening there is that the radius and ulna are rotating around each other at the syndesmosis that's between them. For the syndesmosis in the leg, between the tibia and the fibula, it does not allow that much movement, or as much movement as you have in the radius and ulnar, or I guess I should say the radio-ulnar syndesmosis. The figure here is showing these examples of these fibrous joint types and little diagrams of them. So first, for the suture joint, you have a diagram of it here. You can see the two bones in the joint have this complicated edge, and it's basically made so that they will fit together perfectly. And then the tiny little gap that's there is filled in with collagen fibers. So you would find that primarily in the skull, well, basically in the skull, between bones of the cranium and the face. You also have the gomphosis, also found only in the skull, between the teeth and either the maxilla on top or the mandible inferiorly. So there you have little sockets in the maxilla or mandible, and the tooth forms like a peg that fits in there, and you have your little periodontal ligaments, or little collagen fibers, that stretch across the gap between the tooth and the maxilla or mandible. And you do have a small amount of movement that's possible there, where the tooth can be pushed slightly deeper into its cavity. Then finally, you have the syndesmosis. This is the syndesmosis between your ulna and the radius in the arm, so it would be called a radioulnar joint. And this is just zoomed in on that membrane, or the interosseous membrane, also called the interosseous ligament between those two bones. Next, you have the cartilaginous joints, and there's two subtypes of cartilaginous joints, the synchrondosis and the symphysis. Both of them, or I guess I should say the difference between them, is basically what type of cartilage is holding the bones together in the joint. So for the synchrondosis, the bones are held together by hyaline cartilage, and for the symphysis, the bones are held together by fibrous cartilage, which is a lot stronger, but isn't very good at reducing friction. If you're thinking about the epiphyseal plate as a joint, then it would be classified as a synchrondosis joint because you have hyaline cartilage in the epiphyseal plate, and it's separating the two regions of a long bone, the epiphysis from the diaphysis. Of course, once the epiphyseal plates close and all you have left there is that little marker, the epiphyseal line of where they used to be, that is not a joint anymore because the epiphyseal line is made of osseous tissue. So it's actual bone tissue, it's just part of the bone. But you also have other synchrondosis joints in the body, like the costochondrial joints, for instance, would be would be the major example actually. So the costo there just means ribs. Costal bones are ribs. So a costochondrial joint is between a rib bone and cartilage. So those are both shown in this diagram here. Here you have a long bone with the epiphysis and the diaphysis and the epiphyseal plate separating the two. Since this is made of hyaline cartilage, you can consider it as a type of synchrondosis joint. And then in the rib cage, we have the costochondrial joints between the ribs and cartilage. For the other type of cartilaginous joint, the symphysis, where the bones are held together by fibrous cartilage, the main examples of that type of joint would be found in the vertebral column. So the intervertebral discs are actually a type of joint between each vertebra. And those are made, or the capsule for those joints is made by fibrous cartilage. So you would have just this kind of hollow ring of fibrous cartilage that is wrapping around the vertebrae and connecting them to each other. And then in the middle of that, you would have the spinal cord coming through. Another example of a symphysis joint is the pubic symphysis, which joins the two pelvic bones in the front or anteriorly. So you have diagrams of those joints here. The intervertebral discs between the vertebrae in the back, and the pubic symphysis between the two pelvic bones, in the front between the two pelvic bones. Those are both symphysis joints. Most of these joints are amphiarthrotic. Maybe I shouldn't say that actually. In these examples that we've talked about, actually the synchrondosis are synarthrotic and the symphyses are amphiarthrotic. So of course you don't have any movement at the epiphyseal plate apart from, growth, which that doesn't really count. So that's a synarthrotic type of joint. The costochondrial joints are actually also synarthrotic. They're not supposed to move. The intervertebral discs, though, of course, do move. You can rotate your whole back quite a bit, but each individual intervertebral disc does not rotate very much. It only allows a very small amount of rotation between the vertebrae. So it's classified as an amphiarthrotic joint. The pubic symphysis as well is amphiarthrotic, and you might not think about it as moving because, usually it doesn't, but during childbirth, then it does move, just to kind of stretch a little bit. It'll also move a tiny bit as you're walking to kind of help distribute the forces of walking in the body and kind of your impact with the ground. And that brings us to the synovial joints, which again are the joints that allow the most amount of movement. So they are all diarthrotic joints that allow a good amount of movement. And they have kind of a more complicated structure than the rest of the joints because they have that empty space in between the bones that is filled up with synovial fluid. So first we'll talk about the structure or the anatomy of synovial joints, and then we'll go into the types of synovial joints and the movements that they can do. So in a synovial joint, like the one pictured here, which is the knee joint, you have a capsule around the joint. So where the bones come together, that region is kind of enclosed with this capsule that's made out of dense irregular connective tissue. Actually, you have two layers to that capsule. Oh, let me back up just a bit. That capsule is called the articular capsule. It can also be called the joint capsule. And yeah, it has two layers. The first is the fibrous layer, that's the thickest layer, and the outermost or most superficial layer made of dense irregular connective tissue. Then you have the inner layer, which is called the synovial membrane, and that's formed of loose connective tissue. The synovial membrane doesn't just line the interior of the articular capsule, it actually also lines the surface of the bones where they're kind of sticking into the capsule, or where they're enclosed by the capsule. The only exception would be the surfaces of the bones that are actually participating directly in the joint, which are called the articular surfaces. Those are coated with articular cartilage instead of with the synovial membrane. So at the actual articulating surfaces of the joint, you have this thicker blue articular cartilage, and then away from the articular surfaces, you have the bone lined with synovial membrane that is continuous with the synovial membrane lining the interior of the articular capsule. The synovial membrane is actually responsible for creating the synovial fluid that fills the articular capsule up. Or I should say that fills up the cavity inside the articular capsule, which is called the synovial cavity. So I mentioned that a job of the synovial fluid is to kind of cushion the joint. As the joint is, exposed to forces, and especially if it's like a load-bearing joint, it's under kind of a lot of stress. So the synovial fluid will help to kind of resist compression in the joint and absorb any shock that moves across the joint during movement. It also reduces friction between the articular surfaces or the articulating surfaces of the bones, so that as they move past each other, they don't like rub past each other, but they just kind of smoothly glide past. And it's also very important for distributing nutrients to those interior structures of the joint, because as we're going to see in a moment, the synovial joints do not have a strong blood supply at all. Basically, only the articular capsule is receiving a blood supply. Everything else that's in there is receiving its nutrition from the synovial fluid that is made by that synovial membrane within the articular capsule. So just to kind of summarize here, in our structure of a synovial joint, we have the articular capsule surrounding the joint, also called the joint capsule. So your two bones come together, and then that area where they actually meet is surrounded by that articular capsule. The articular capsule encloses a space called the synovial cavity. It's actually also called the joint cavity. The synovial cavity is filled up with synovial fluid. The synovial fluid is made by the synovial membrane, which is the innermost layer or the deepest layer of the articular capsule. The synovial membrane actually also coats the surface of the bones where they are protruding into the articular capsule, with the exception of the actual articular surfaces of the bones that are coated with articular cartilage, which is hyaline cartilage, by the way, to reduce friction. So of course that articular cartilage is reducing friction there. The synovial fluid itself is also reducing friction between the bones in the joint, and absorbing shock for them and distributing nutrients to those interior structures. Within the articular capsule, you have blood vessels and you also have nerves. So the blood vessels will be traveling to the synovial membrane within that articular capsule, and the blood is actually used by the cells of the synovial membrane to make synovial fluid. So therefore, some of the nutrients that are in the blood will end up in the synovial fluid. The structures inside the joint capsule, especially, or inside the joint cavity, especially the articular cartilage itself, they don't have any direct blood supply. So there are no blood vessels that run to the articular cartilage. All of the nutrients that that cartilage is receiving is coming from the synovial fluid. That's kind of the reason, or a big part of the reason, why joints are kind of slow to heal. Just because there's a very limited supply of nutrients in blood, well, no blood, and limited nutrients for the articular cartilage. So once you've damaged it, it's kind of hard, or it takes a long time to fix it. You also have nerves that enter the articular capsule for sensory perception, specifically for proprioception, or your sense of kind of where your body is at in space, also for pain. Oh joy. So you have kind of two types of nerve endings that you find in the articular capsule. Some of them are just free nerve endings, and some of them actually are encapsulated, so they have a little structure around them that is helping them perform sensory transduction and convert, sensory impulses into nerve impulses. This diagram here is showing kind of that blood supply and nerve supply. So you have blood vessels. Of course, vessels would be traveling into the bone, but they also travel through the articular capsule. So you have some capillary beds there within the articular capsule, but most of the capillary beds are going to be in the synovial membrane part of the capsule. Then you have veins carrying the blood away. And then you have nerves that are found in the articular capsule as well. Some of them have free nerve endings, like this one. Some of them have encapsulated nerve endings, like this one. So they're both sensing, I guess, different aspects of just stretch in the articular capsule, which would be related to the position of the articular capsule and therefore the position of the overall joint. So this is mostly giving you information about where that joint is located in space, or kind of what position it's in. How kind of bent it is, or how the bones have moved vis-a-vis each other. And then, of course, if things are kind of going wrong in here, if your capsule is under stress, if it's kind of stretched out or inflamed, that's going to be picked up by pain receptors. That would be free nerve endings in the articular capsule. So that's the basic anatomy of a synovial joint. But in addition to that, you also have structures that you're going to find around most of the synovial joints. And it can get quite complicated. Some of these joints have a lot of structures kind of wrapped around them and in that general area. Those structures are designed to help support the joint, give it stability, and also to help reduce friction associated with movement of the joint. So we'll just go through those structures now. The first would be ligaments, and then you also have tendons. So the difference between a ligament and a tendon is just what it's attached to. A ligament is attached to two bones so it's attached to bone on both ends. For a tendon, that's attached to bone on one end, and then on the other end, it's attached to a muscle. Both of those are formed from dense, regular collagenous connective tissue. So, it's basically collagen fibers, very, very strong since the fibers are all running the same way. For the ligaments, we have kind of two types, either intrinsic ligaments or extrinsic ligaments. The intrinsic ligaments travel within the articular capsule, and the extrinsic ligaments basically do not. But they actually don't have to be outside of the articular capsule. They could be outside the articular capsule entirely, or they could be actually located entirely inside of it, so that they're actually within the synovial cavity or within the joint cavity. So an intrinsic ligament is specifically like part of the articular capsule wall, and the extrinsic ligament is on either side of that wall, but not a part of it. Either way, though, the function of the ligament is just to provide additional strength and stability to the joint. So the joints like the knee and the shoulder that are kind of the least stable by their inherent structure. They'll tend to have a lot of ligaments running across the joint in different places and connecting the bones together. You also have tendons, as I just mentioned. Those are going to be connecting muscles to the bone, not bone to bone. But a lot of those tendons will actually run across the joint, across where the bones are connecting to each other, and that helps stabilize the joint as well. It actually allows the muscles to help provide stability and strength to the joint. It also means that when your muscles contract, they're not tugging like directly on the joint. So the tendon for the muscle would run like across the joint and connect to the bone somewhere on the far side, so that whenever the muscle contracts, the main kind of force that the muscle is exerting on the bone is going to be located right where the tendon is connected to the bone, and that's going to be at some little distance away from the joint itself. So you're redirecting the forces or the strain of muscle contraction away from the joint itself. So again, with your joints that are a little less stable, like the shoulder and the knee, you're going to have a good bit of the stability of the joint provided by these tendons that are running across it. Another structure that helps stabilize certain synovial joints is a meniscus. The plural of that is menisci. Meniscus is a pad, basically just a padding that's made out of fibrous cartilage that is found between the two bones within the articular capsule. So it's basically separating the two bones from each other, and that way when you have forces on that joint, it's just providing some padding or some cushioning for the bones. The most famous menisci are found in the knee. In the knee, you have a lateral meniscus and a medial meniscus, separating the tibia and the femur in the knee. So one role of the menisci in the knee is to reduce friction between those two bones as they're moving past each other, so they're not actually like contacting each other. But another role is to just kind of provide some stability there and distribute force. So you don't have just kind of like one point on one bone, pressing onto the articulating surface of another bone. Instead, you have that bone pressing onto the meniscus, and the meniscus will distribute that force of the bone pressing like across the entire surface of the meniscus, and therefore across the entire surface of the entire articulating surface of your other bone there. So here you have a couple diagrams showing these structures. On the top you have the knee, on the bottom is the shoulder. So for the knee here, well, I guess I should say for both of these joints, these are not all of these structures that are involved in stabilizing these joints and located around these joints. Most of the structures that stabilize these joints in each case have been kind of cut away in these diagrams to let you see a little more interior detail on the joint. For the knee here, you have some ligaments. This is a ligament between the tibia and the femur. Here's a ligament between the fibula and the femur. These are both considered extrinsic ligaments. They would actually be located outside of the articular capsule. The articular capsule is not illustrated in this diagram. Here you have a tendon, which is kind of cut off here, but is attaching to the femur and attaching to the popliteus muscle, which is just a small little muscle in the back of your knee. You also have some ligaments inside, inside the capsule. So this anterior cruciate ligament here, you may have heard of before because it's frequently injured. That would be an intrinsic. That would be an extrinsic ligament that is located inside the articular capsule. You also have a ligament that would be a part of the articular capsule here, so that's an intrinsic ligament. And then you have these two pads between the bones themselves. So these are the menisci, or the lateral and medial menisci in the knee. Then in addition to ligaments, tendons, and menisci, we also have pads of adipose tissue, bursae, and tendon sheaths that also help to stabilize and protect joints. So first, the adipose tissue, just anywhere within the structure of a joint, or those kind of ancillary structures that are around the joint, like the ligaments and tendons, anywhere where you have little spaces between them that would be empty, you'll usually just have little pads of adipose tissue filling up that extra space. That's useful not only for, just filling the space up, but it helps to absorb any shocks that may be traveling across the joint, from impacts between your body and the world around you. Then you have the bursae and the tendon sheaths. A bursa is basically a little pouch that is very much like an articular capsule in its structure, except that it's not enclosing a joint. It's just a little pouch that is filled with synovial fluid. So you find bursae kind of tucked in amongst the ligaments and tendons that are surrounding a joint, and helping to give it structure. The purpose of the bursa is not to provide like structural support to the joint, but to reduce friction as the joint is moving. So, of course, when you have a bunch of these ligaments and tendons around a joint, and if the joint is going to be moving, those ligaments and tendons are going to be sliding past each other, and they can actually end up rubbing on each other, and that can cause inflammation and damage to them. So the bursae are basically, preventing that damage from occurring. So if you have two ligaments around a joint, they might be separated from each other, like two ligaments that would rub against each other. They might be separated from each other by a bursa. Then as they're moving, they don't really move past each other so much as just they squish the bursa around, kind of like a beanbag. Or you can imagine if you had like a water balloon that was kind of maybe halfway full of water, and you hold it between your hands and kind of rub your hands past each other. Your hands wouldn't be actually rubbing on each other. Instead, you're just rolling that bag around in your inner hand. So that's kind of how the bursae work in joints. Then you finally have the tendon sheaths. A tendon sheath is just a special type of bursa that is wrapped around a tendon. So not all joints will have the tendon sheaths, and not all tendons have tendon sheaths, just specific ones. And their role is very much just the role of the bursae, just to reduce friction, as those tendons might be sliding past or rubbing against structures that are around them. Instead, the tendon sheath will be shielding them from that rubbing. So again, we have diagrams of the knee and the shoulder here. In the knee diagram, you can see this is the patella, or the kneecap bone, and beneath the patella you have a fat pad, or a little pad of adipose tissue. Then in the shoulder diagram, this image is showing a lot more of the structures around that shoulder joint than the previous diagram had shown. Of course, the previous diagram showed very little, basically only this tendon here for the biceps brachii. But this again is not all. It's not all of the structures around the shoulder joint. It's again only some of them. But you can actually see the articular capsule here. These fibers of collagen are primarily belonging to the articular capsule, although within them you do have some ligaments like the glenohumeral ligaments here that would actually be intrinsic ligaments that are a part of that articular capsule, and you have some extrinsic ligaments shown. Actually, not this one, but this one. This one's a tendon. And here you have the tendon for the biceps brachii that would actually be running up over this entire joint and attaching to the scapula on the other side of the joint. You can see just the beginnings of the tendon sheath for this tendon, which is going to follow the tendon as it travels up through the shoulder joint structures, just to prevent it from rubbing against them. So you can imagine how this tendon might be rubbing against this tiny little ligament here if you didn't have that tendon sheath. Then these other pads are bursae located around the shoulder joint and in between the ligaments and tendons of the shoulder joint to reduce friction between them. So that basically covers the structure of our synovial joints and the structures around them that are needed to stabilize and protect them and reduce friction as they're moving. So before we go on to the types of synovial joints, I'll just want to talk real quick about arthritis, which is a very common disease that affects people in their older age, and is definitely the most common joint-related disease. So in arthritis, what's going on is that you have the articular cartilage inside of the joint that is actually lining the articular surfaces of the bones in the joint. That articular cartilage is degrading, and that is causing inflammation in the joint in that synovial cavity. And in the articular capsule. It's actually kind of a positive feedback loop where you get some degradation of the articular cartilage that causes inflammation. The inflammation actually causes more degradation of the articular cartilage, which causes more inflammation, which causes more degradation, so on and so forth, until you end up with a joint whose structure has been quite badly worn away. A lot of the time, as this disease is progressing, you're going to have additional structures become involved in that inflammation. Basically, wherever you have inflammation occurring, if it's kind of going on over a longer period of time, it's going to cause damage in whatever tissue it's occurring to. So this inflammation of the articular capsule and the structures within it can actually end up kind of spreading and damaging some of those ligaments and stuff that are around the joint. So in the diagram here, you can see a healthy synovial joint compared to a synovial joint that's affected by arthritis. So you can see in this joint the degradation of the articular cartilage compared to the healthy joint. So it's not just a smooth layer, but there's places where it's worn down and even worn away completely. And then this kind of redness is indicating swelling in the articular capsule, especially of the synovial membrane. And you can see it's also, just swollen, which is another sign of inflammation, swelling and redness. So this inflammation is actually an ongoing immune response to the damage that's occurred to the articular cartilage. That immune response is causing damage of its own. So it is releasing chemicals that are basically damaging cells in the area that's exposed to the inflammation. So you can see this has gone on for a while, and the bone itself is being kind of worn away by this inflammation. And also wherever you have the articular cartilage having worn away, the bone is being damaged there as well. So as this disease progresses, the bones themselves that participate in the joint can actually be chewed up by that inflammation. Oh, and I should mention the naming of arthritis. The arth part there is coming from the joints themselves. That tells you that this refers to the articulations. So like the functional joint categories, the synarthrosis, amphiarthrosis, and diarthrosis, those also have that arthur. This is technically the R after the arth. Is also part of that little word stem that wherever you see it, you know that we're talking about joints, basically. And then the itis there just means inflammation. So like hepatitis, that means inflammation of the liver. Arthritis, inflammation of the joints. Wherever you see itis, that just tells you there's inflammation going on. We've got 3 different types of arthritis that are classified based on what causes them. So first you have osteoarthritis. That's just normal wear and tear on the joints. So of course as you're getting older, your body's kind of regenerating less well, and you've just been exposed to more longer time period for damage to occur to your body parts. And so that's going to affect your joints as well. So you can have some of that normal wear and tear in your joints kind of adding up over time and ending up with damage to the articular to the articular cartilage that actually doesn't get healed. and especially because the articular cartilage does not receive any direct blood supply, all of its nutrients are just coming from the synovial fluid. That makes it very hard, or just kind of very slow going to repair it once it's damaged. And that, of course, is going to affect an older person even more so, since they're just having it takes them longer to repair anything when they're older. Then you have rheumatoid arthritis, which is actually an autoimmune condition where the immune system is attacking the joint. And finally, you have gouty arthritis, also just called gout. In that condition, you have crystals of uric acid that are actually forming within the joint and causing damage to the articular cartilage. So that is going to occur mostly in people who have compromised kidney function. Normally, all of that uric acid should be, filtering out from your blood in the urine. That's kind of why we call it urine, or part of why we call it urine. But if the kidneys aren't kind of functioning properly, then you can have uric acid building up in the blood to a higher level than what would be normal. And if it gets too high, then you can end up having these crystals deposit in the joints, which then causes a flare-up of gout. So now we'll get into the actual types of synovial joints. Just like for joints overall, they're classified functionally and also structurally. Same thing for synovial joints. So for joints or articulations as a whole, you have the functional classifications, the synarthrosis, the amphiarthrosis, the diarthrosis. You also have the structural classifications, the fibrous joints, the cartilaginous joints, the synovial joints. For synovial joints, they have their subtypes by structure, just like the fibrous and cartilaginous joints do, but they also have subtypes by function. So those subtypes are related to the type of movement that the joints support, and specifically the number of axes that each synovial joint is able to rotate around. So basically, you can kind of imagine an axis moving, or an axis through the joint, and the joint moving or rotating around that axis perpendicular to it. So for example, here in the elbow, here you have an imaginary axis running through the joint, and of course you can kind of flex or extend your elbow, moving your arm up or down, in which case you're rotating the joint around this imaginary axis running through it. So different synovial joints will be able to rotate around different numbers of axes. Actually, the first classification is non-axial, which is for synovial joints that do not rotate around an axis at all. They are basically doing kind of planar movement where bones are sliding past each other in one plane. And there's a few examples of that type of synovial joint, mostly in the wrists and the ankles. So the intercarpal joints in the wrists and the intertarsal joints in the ankles tend to be non-axial. So you have, an example of an intercarpal joint shown right here, where these two carpal bones are sliding past each other. And they're not rotating around each other. Of course, they're not moving perfectly in a plane because their surfaces are not perfectly flat, but there's no rotation going on there. So that is a non-axial joint. Then you have uniaxial synovial joints, where you have just one axis of rotation for the joint. The elbow joint is an example of that. So your elbow can only rotate the one way. Therefore, it's a uniaxial joint. Then you also have biaxial joints, where the joint can actually rotate in two different directions, so it can move around two axes, not just one. And finally, you have the triaxial joints that are also called multiaxial joints, that move around three axes, which is, of course, all of the axes that exist. So whether you call them multiaxial or triaxial, those joints have the most amount of movement that's possible for any joint. They can move in three different ways. And I have examples for the biaxial and triaxial joint types on the next slide here. So For your biaxial joints, a common example is the metacarpal phalangeal joints in your hands that we actually did mention previously. It was when we were going over the naming of articulations. So of course, you can rotate your fingers like well, like shown here, basically like moving them in towards your palm or moving them out straight. So that is one axis of rotation. You could imagine a pole, traveling through your knuckles, and the finger bones can rotate around that pole. So that is one axis of rotation for those joints. But you can also spread your fingers apart and then bring them in, to rest against each other. So that's a different type of movement. That's movement in a different direction or around a different axis. For that, you would imagine kind of a pole sticking straight through each knuckle, like coming into the, coming out the back of your hand. And you can rotate the fingers around that axis, not maybe a lot, but a little bit. So that is movement around two different axes, or biaxial movement for your joints between the fingers and the hand, or the metacarpal phalangeal joints. And finally, the shoulder is the most common example of the triaxial or multiaxial joint type. You also have the hip as an example of this type of joint. But you can move your arm like forward, like out in front of you, or you can move it posteriorly, so pointing out behind you. That is movement around one axis. You would imagine maybe a pole sticking, through your shoulder so that it connects like to your other shoulder, and you can swing your arm around that imaginary pole. So that is one axis of movement. You can also lift your arm like straight out from your body. So that is a different form of movement. For that one, you would imagine your axis or your pole sticking straight through the shoulder joint, running out in front of you and behind you, and you're rotating the arm or the shoulder around that imaginary axis. So that's another axis of movement. Then finally, the shoulder is able to actually rotate. So the humerus can, just spin basically on its spin along its length. So if you were to hold your upper arm at your side and then bend your elbow and move your hand kind of from in front of you to the side of you and back again, what you're doing there is actually rotating your humerus. So for there, you would imagine a pole just sticking basically right through the joint, up and down, like traveling, superiorly and inferiorly. And you are rotating around that imaginary axis. So that's your third axis of rotation for the multiaxial or triaxial joints. So those are our subtypes of synovial joints by function. Then we have subtypes by structure, and there's 6 of them. So first you have the plane joints. Those are also called gliding joints. All of the synovial joints that do non-axial movement are plane joints or gliding joints. So the primary examples would be your intercarpal or intertarsal joints in the wrist and ankle. You also have a pivot joint, which does a type of uniaxial movement, specifically where one bone is like spinning on its axis. So the best example of that type of joint is actually found in the vertebral column between the top 2 vertebrae, between the atlas and the axis vertebrae. So that's illustrated right here. You have your axis, which is the second vertebra, and your atlas is the first vertebra. And the axis has a little projection called the dens that sticks up into the little opening in the center of the atlas vertebra. And you have a joint there between the atlas and the axis. That is a pivot joint, where the atlas bone can basically rotate around this little projection. So you could imagine a pole stuck through a washer maybe. You could rotate the washer around that, well, let's call it a screw. You could imagine rotating a washer around a screw. That's basically the way that the atlas is able to move around this projection from the axis. So that is a form of uniaxial movement. There's only one axis or one way that joint can move, one way it can rotate, rotating basically around a long axis. You also have hinge joints that are also uniaxial. A good example of that is your elbow joint. So you could imagine in that type of joint the structure basically being like a hinge on a door. So it allows, a hinge on a door allows the door to move one way. And same way the elbow is able to move in that same just one way. So you can move your elbow or your forearm kind of up and down, rotating it around the kind of hinge on the humerus. So in that case, the bone is not spinning, it's more moving angularly through space. So that's a different type of movement than what's allowed by the pivot joint, even though in both cases the joint is uniaxial. The pivot joint is allowing a bone to rotate, and the hinge joint is allowing a bone to move angularly through space. So you can have, like, the whole body part is kind of rotating around an imaginary axis. I don't know if that makes sense, but the bone is not rotating around itself. Then you have condylar joints and saddle joints. Those are both types of synovial joints that allow biaxial movement, so movement in two axes. The condylar joints are also called ellipsoid joints sometimes, or condyloid joints. They're very similar, just the structure is a bit different. So you can see the condylar joint illustrated here. A good example of it would be the joints between the metacarpal bones and the phalanges, so the metacarpal phalangeal joints in the hands. The saddle joint is shown here. A good example of the saddle joint is the joint between the first metacarpal of the thumb and the carpal bone, the carpal bone called the trapezium. So basically where the thumb attaches like to the wrist, you have a saddle joint right there. As you're looking at the kind of diagram of the structure of the joint, you can notice that the condylar joint has kind of this rounded projection and a light groove or depression on the other joint, on the other bone in the joint. Whereas in the saddle joint, the grooves on each bone are much deeper. So the saddle joint basically has a more stabilized structure. Or I guess I should say it has a more robust connection point between the two bones in the joint, which usually would be associated with more stability. In both cases, there's two ways that each bone can rotate around the other in the joint, or can move, vis-a-vis the other in the joint, as kind of indicated by the arrows there. So, you can move your fingers forward to bring them into the surface of your palm. You can also spread them apart. So that's your movement in two different axes. That's allowed by this condylar joint between your fingers and your hand, basically. Then for the thumb, you can move your thumb forward and backwards. You can also move it out from the rest of your fingers and in next to the rest of your fingers to lie against your hand. So that's movement in the same two axes as for the metacarpal phalangeal joints. But you can notice, the movement is more, especially for bringing your thumb out and in against your hand. You can move it a lot further out than you can spread the other fingers out, basically. So the saddle joint allows more movement in that sense than the condylar joint. Then finally, you have the ball and socket joint, which is the triaxial or multiaxial type of synovial joint that allows movement in three different axes. So you basically have a couple of those in the body. You have the shoulder joints and the hip joints. In each case, one bone kind of has like a ball-like protrusion on its surface, and the other bone has a socket for it to fit into. Of course, in the case of the scapula, it's, not much of a socket. The glenoid cavity there that the humerus fits against is just kind of a shallow depression. But in the hip bone, the femur has a really well-developed ball-looking thing on the end of it, and the pelvis, or the pelvic bones, have a pronounced depression, like a circular cavity in them, like for a ball to fit in there for the femur. The ball and socket joint allows the most movement of any type of joint. You can have actual rotation of the bone around itself, the bone just basically spinning in place. And you can also have movement, I guess kind of up and down and side to side, so in the other two axes as well. And they tend to be the least stable out of any of these synovial joints. So if we were to rank these joints by how much movement they allow, in general, plane joints allow the least. Then you have pivot joints and hinge joints allowing a little bit more. Then condylar joints allow more still. Saddle joints allow even more movement, and ball and socket joints allow the most movement. And we'll finish up this chapter by talking about the specific types of movement that synovial joints allow. So you can categorize the types of movement at synovial joints into 4 basic categories. First, you have gliding, which is that non-axial movement where the bones are just sliding past each other, not rotating around an axis or anything. Only the plane joints can do gliding movement. Then you have angular movement, where you're altering the angle between 2 body parts or the angle between 2 bones, the bones in the joint. All synovial joints are capable of angular movement, except for the plane joints and the pivot joints. So hinge, condylar, saddle, ball and socket, they can all do angular movement. And we have specific types of angular movement that we'll go into in a moment. So you have flexion, extension, abduction, adduction, and circumduction. Also a couple others that we'll mention, like a couple kind of like subtypes or special types of flexion, extension, abduction, and adduction. Then you have rotational movement at some synovial joints, specifically at pivot joints and ball and socket joints. In the rotational movement, a bone is rotating around its longitudinal axis, which basically means that if you imagined a pole running through the bone along its length, just the bone spinning around that pole would be rotational movement. And you have 2 types of rotational movement, internal and external. And then finally you have special movement. So basically any type of movement that occurs at a synovial joint that cannot be categorized as gliding or angular or rotational, we consider that a special type of movement. And there's a number of examples of special movements that certain synovial joints can do. So it wouldn't be like a particular type of synovial joint that is able to do these movements. It would be like 1 or 2 specific joints in your whole body that are able to do each of those types of movement. So we're not really going to get into the special movements. That goes maybe a little bit more into detail than what we require. So we'll just focus on the gliding, angular, and rotational movements. Before we go into the angular and rotational movements in more detail, I just want to remind you real quick about our standard anatomical planes. So first you have the transverse plane, also called the horizontal plane. That's basically cutting the body into a superior half and an inferior half, or a superior part and an inferior part. Then you have the frontal plane, also called the coronal plane, that is dividing the body into a front and a back part, or into an anterior and a posterior part. And finally, you have the sagittal plane, running down the body, maybe at the midline or maybe to the side of the midline, that is dividing the body into a right part and a left part. So these planes are going to be useful for kind of understanding the different types of angular movement. So just to go over gliding movement really quick again, that is again movement that occurs at plane joints by structure, or like functionally it would occur at non-axial joints. Actually, let me say that again. Gliding movement occurs in non-axial joints. That's the type of functional joint classification that they occur in, or that it occurs in, and it also occurs in plane joints, which is the structural classification of the type of synovial joint that it occurs in. Gliding movement is always linear, basically movement in a plane where 2 bones are gliding or sliding past each other, and it mostly occurs in your wrist and your ankle. So again, you have the example of 2 carpal bones sliding past each other, basically. Then you have your angular movements, where the angle between body parts is actually changing. So the first kind of set of angular movements would be flexion and extension. In flexion, you are decreasing the angle between two body parts. In extension, you are increasing the angle between two body parts. So if you have your elbow bent so that your forearm, is in towards your shoulder, that is flexion at the elbow joint. If you have your elbow extended so that the arm is straight, that is extension at the elbow joint. Some joints can also do a special type of extension that's called hyperextension. So extension is where the angle between body parts is increasing. So for instance, for your elbow, if you have your arm out straight, then the angle between your upper arm and your forearm is 180 degrees. And you can't increase it any more than that. So the elbow cannot hyperextend. That's its maximum extension. But for certain joints like the shoulder joint or the hip joint, you could actually keep increasing the angle between the body parts once you get it to 180 degrees. So anytime the angle is able to increase above 180 degrees, that is hyperextension of the joint. Practically, what that would look like would be if you, let's say for your hip joint, if you have your leg just straight, that is an extended hip. So the angle between your torso and your thigh is 180 degrees, or it's straight. If you were to move your leg forward or anteriorly, you would be flexing your hip, decreasing the angle between your thigh and your torso. Then when you move your leg back to be straight up and down, then you've extended it again. But you can also move your leg back behind you. If you do that, then you're increasing the angle between your torso and your thigh above 180 degrees. So that would actually be considered hyperextension. Then for flexion, you also have like a special type of flexion that some joints can do, which is lateral flexion, which is just anytime you're flexing to the side. So usually in extension, hyperextension, and flexion, you're moving in the sagittal plane. So the sagittal plane divides the body into into a right and a left half. If you're moving in the sagittal plane, then you're basically moving just within that left half, or within, let me say that different. So the sagittal plane is dividing your body into a right and a left half, and it's basically stretching out anteriorly in front of you and posteriorly behind you. So anytime you're moving a body part anteriorly in front of you or posteriorly behind you, you're moving in the sagittal plane. So extension, hyperextension, and flexion are movements that we think of as occurring in the sagittal plane in general. The exception would be lateral flexion, which is movement in the frontal plane, or the plane that divides your body into a front half and a back half, or an anterior half and a posterior half. So the frontal plane is extending, away on your right side and then away from you on your left side, dividing you into a front and a back half. So if you're moving in the lateral or in that frontal plane, you're going to be moving, side to side on the left side or on the right side. So we have some images here kind of trying to illustrate those movements, because they're kind of harder to describe verbally than they are to see. So first we have basically flexion and extension shown with the elbow joint. So when your elbow is moving for your arm to be straight, that is extension. When you're bending it so that your arm is coming in towards your shoulder, that is flexing it. That's all the elbow can do. But for your shoulder and for your hip, you can not only do extension and flexion, but you can also do hyperextension, where you bring the limb basically behind you. So again, for your hip, when the body is straight and the leg is straight up and down, that is a fully extended hip joint. That's 180 degrees between your thigh and your torso. If you were to move your leg behind you, you would be hyperextending it, increasing the angle between your torso and your thigh above 180 degrees. Then your neck and your spine can also do, or they can do, lateral flexion. So if you bend over to the side like this, or if you bend your head to the side, that is lateral flexion. And that movement, you notice, is in the frontal plane, where it's left and right. Whereas this other movement of like the shoulders and the hips is front and back, so it's in the sagittal plane. Then our kind of second pair of angular movements that are changing the angle between body parts would be abduction and adduction, which are really easy to get mixed up because there's only a difference of one letter between their names. But abduction is movement away from the midline. Could be either the midline of the body or it could be the midline of a limb. Adduction is the opposite thing. It's movement towards that midline, whether it's for the whole body or for just a limb. You can remember the difference, or at least I remember the difference, because abduction is like when you're abducting the body part, taking it away from your midline. Yeah, so abduction is moving away from the midline. So that would be like if you just kind of hold your arms down at your side, then they are in the adducted position where they're close to the midline. Then if you raise them to kind of point out away from you, then you are abducting them. You're moving them away from the midline. Same thing with your legs. When your legs are, together and straight, then they are adducted. If you spread them apart, you are abducting them, moving them away from the midline. And you can also abduct and adduct your fingers and your toes as well. So when you spread your fingers apart, you are abducting them, moving them away from the midline of the limb. When you put your fingers together, you are adducting them, moving them in toward the midline of that limb, and the same thing for your toes. So abduction and adduction refer to movements that are occurring in the in the frontal plane. So that's, again, the plane that divides your body into a front half and a back half, or an anterior half and a posterior half. So if you're moving in the frontal plane, then you're basically moving left to right, because that plane extends out to your left and out to your right. But then you also have like special types of abduction and adduction, which are called horizontal abduction and horizontal adduction, which is basically movement, away from the midline for horizontal abduction or toward the midline for horizontal adduction, but occurring in the transverse plane. So the transverse plane divides your body into an upper half and a bottom half, or into a superior half and an inferior half. So basically, any time that you're moving a body part in a way that's parallel with the ground, then you're moving in the transverse plane. And again, we have our pictures here. On the bottom, you have regular abduction and adduction. So you can do it for the arms and the legs. If you move them out from the midline, you are abducting them. For your fingers and your toes, when you spread them apart, you are abducting them. Then if you move your arms and your legs close into the midline of the body, or close to the body, you are adducting them. When you line your fingers up together, and the same for your toes, you are adducting them. But if you were to hold your arm out at your side and extend the shoulder, and then bring your arm in towards, to point in front of you, that is horizontal adduction. If you have your arm pointing out in front of you and you move it to your left or right side, then you are doing horizontal abduction, where the movement is occurring in the transverse plane rather than the frontal plane. The last type of angular movement is circumduction. Circumduction is actually a combination of multiple types of angular movement that make a limb basically move around in a circle. So to do circumduction, first you have to do flexion of that limb, then abduction, then extension, then adduction, and just repeat it in a cycle. And you could do that like in the reverse order as well. So you have in this illustration here the shoulder joint is shown doing circumduction. So the humerus is going to appear to be moving in a circle. So you're going to start maybe by flexing the shoulder joint, which would move the humerus forwards, forwards in space. It's a little hard to indicate that with the pointer. Then next you might do adduction to move the humerus in towards your body. Then you could do extension, moving it back behind you, or back straight and then even back behind you, which technically would be hyperextension. And then you can do abduction where you move it out from your body, and then more flexion to bring it forward. If you just repeat those movements in a sequence, you're going to get the limb rotating, moving out, then in towards you, then back, then out the other way, then out in front of you. Oh my God, I'm sorry. You can move your arm in a circle. That is different from actually rotating that shoulder joint. So if you are rotating the joint, then the humerus actually doesn't appear to move in space. It's just spinning basically around itself. So that is proper rotation. Circumduction is totally different. You're having one end of the bone move around in a circle and the other end stay still. So there's some joints that can do circumduction that cannot do rotation. For example, that thumb joint between the first metacarpal in the thumb and the carpal bone in the wrist that the thumb attaches to, which is the trapezium, that joint is able to do circumduction, but it cannot do rotation. Because it's a saddle joint, it can't do rotation. It only does angular movement. Biaxial movement. Basically any joint that can do biaxial movement or triaxial movement can do circumduction. But then, of course, only the ones that can do triaxial movement can do true rotation. So you can't rotate your thumb. You can't spin your thumb around itself, but you can circumduct it, bringing it forward, then in, then back, then out, and over again. So the last type of movement that we're going to talk about is rotational movement. And again, there's two types of rotational movement: internal rotation and external rotation. Only ball and socket joints or pivot joints are able to do rotational movements. Internal rotation can also be called medial rotation. In that type of rotation, you have a body part rotating along its axis, its longitudinal axis, so just basically spinning around itself, but doing it towards the midline of the body. External or lateral rotation is where that body part is rotating just the opposite direction, so it's rotating out away from the midline. So your head is able to do rotational movement because of the pivot joint that you have between the atlas and axis vertebrae in the neck. So if you were to rotate your head, if you have your head like looking straight forward and then you rotate it to either side, that is external rotation because you're turning the head away from the midline. Then if your head is out to the side and you bring it in, then that is internal rotation, where you're bringing the head back to point towards the midline. You can also rotate your shoulder and your hip, since those are both ball and socket joints. So if you rotate the hip, you would mostly see actually your whole leg and your foot spinning. Since the knee doesn't really, technically you guys, the knee does rotate a tiny bit, but we'll ignore that. The knee, we'll just say it doesn't rotate. So when you rotate the hip, the whole leg is going to rotate basically. If you're bringing your feet in towards your other foot, if you're bringing your toes in towards your other foot, that is internal or medial rotation towards the midline of the body. If you turn your hips so that your toes are pointing outwards, that is external or lateral rotation. For all types of rotation, the movement is generally going to be in the transverse plane. So basically it's going to be parallel with the ground in all cases. So that kind of sums up what we're going to talk about, regarding the articulations or the joints for Chapter 8. And it kind of sums up what we'll talk about for the skeletal system. The next system we'll talk about is the muscular system, which of course has to work with the skeletal system in order to move your body. So all these movements around the joints that we've been talking about, the angular movements and the rotational movements, of course, would be powered by the muscles. So we're going to look at those next.